Okay, so what we hope to do in the next half hour and an hour or so is just take you on the journey that we've been on since 2013. And this is really hopefully going to tell you and share with you how we've embedded outcome measures into our clinical practice. We're not professing it's the way to do it, we're just sharing how we've done it. And some of you in the audience I know have been to St Luke's and spent time with us, so apologies to those of you that have already heard this part of the story. So our story started in 2013 when, quite frankly, we didn't have particularly strong governance around our practice. We peer reviewed ourselves against the then peer review standards and we failed miserably. I think for our inpatient centre we'd got about 20% compliance and community was probably a little bit less. So we knew we had to do something, and there was a very clear steer from our chief executive that we needed to look at how we were using our workforce. He wasn't so interested in the peer review results, but what he did see was a lot of time being spent in MDTs and perhaps not the best use of senior clinicians' time. And at that point, we were very fortunate to become part of the Palliative Care funding pilot sites, which really started us to connect with what we were delivering in our organisation with what was happening on a national level and starting to understand how that national agenda influenced the care we were delivering to our patients and their families. So the governance framework at that time, I said it a few minutes ago, it was poor, and we as the executives couldn't really give assurance to our other executives and our trustees about how we were delivering care and what the outcomes for our patients were. I think Antonia mentioned earlier, we got lots of cards from patients, so we could say we're doing a good job, but there was nothing to quantify that. And our processes were scanty at very best. So we had no robust mechanisms to give us assurance other than on our inpatient centre for how often our patients were brought to MDTs, how we actually assessed and validated the care that was being delivered out in community and in our day centres. And sitting alongside that, our assessment processes were really quite poor. And every nurse was doing a very good job, but it was very inconsistent across the organisation. So we had to do something, and in 2013 we started to look at our MDTs. And you've just got up on screen the number of MDTs we had, and I think it'll resonate with a lot of you. They were quite cathartic. We talked a lot about the sexy patients, and some patients never even got discussed. On our inpatient centre, and let's be very clear, it was a 20-bedded and still is inpatient centre. We could spend up to 6 hours a week in MDT, 3 MDTs within that 20, with each consultant leading the MDT. So quite medically led, which at the time was okay, but going forward, we knew we had to change. Within community, the governance framework was incredibly poor because at least on the inpatient centre, our 20 patients got spoken about each week. But in community, if we were lucky, we could give assurance that when they first came into our service, they were talked about. But after that, they got lost in the system, and it was very much reliant on the community nurse identifying that they needed to bring the patient back to MDT, and none of us don't know what we don't know. So actually it was very heavily reliant on gut instinct. And our therapies and rehabilitation centre, our day centre, it was quite frankly just a meeting. There was no regular medical senior nurse presence. The AHP teams came and went, and it was a discussion about whoever we thought we would talk about for that particular day. So the framework was incredibly poor. And we spent on average 13.5 hours a week discussing these patients, but actually these patients came by default rather than good governance. So over the last 3 years, we have done step changes to actually change the way we deliver our care to patients. And MDTs are just a part of that. through being a palliative care funding site, I think we were really privileged because we were able to sit in national meetings and we were able to start to connect the different pieces. We had a light bulb moment in 2014 when we joined Fliss and her team at King's, and they started to share with us what was then POS, I believe, at that time, and we now know more broadly as the Oak suite of measures. And we could see how actually that could start to make a difference to actually validating the care we were giving to patients and the patient being at the centre with their family of the care we were delivering. So over the time we've introduced Karnofsky, we then introduced phase of illness, and then we started through IPOS to look at outcomes and feedback embedding into practice. And I think this is the critical bit, and again it links to something Antonia said. You can do IPOS, but what does it mean? What it means for us is that yes, the patient and family are at the centre, but we're actually developing now a nursing acuity and dependency kit, which IPOS and outcomes feed directly into, and from that we can look at the complexity of our patients, and from that we can determine against our nursing establishment, our medical establishment, and to a lesser degree other parts of the service, so our AHPs, our housekeepers, our hospitality team, the daily flow of our patients coming into our inpatient centre. So rather than our head of inpatient centre saying to me, we're really busy, Judith, we can't take admissions today, me saying, well, why? Well, it's the gut feeling, which I'd then share with my chief exec. The head of inpatient centre and her team can very clearly demonstrate why we can or can't take patients and what level of acuity we have on a day-to-day basis. So really powerful. It's also, by actually embedding IPOS and outcomes into our practice, enabled our ward rounds to be much more efficient and effective because the consultants and the wider team are able to look at the IPOS outcome scores, and before they go into the patient's room, they know what's important to their patient. And a very quick anecdote is, you know, on a ward round not so long ago, the patient had scored severe for constipation. The nursing team said, no, they're absolutely fine. They had the bowels opened yesterday. When the consultant went in, he was able to go straight to that point on the IPOS because that was the most important thing to that patient on that particular day. And the patient had got a problem with the bowels, even though they'd had them open the day before. So it just shows what a difference it can make. It's influenced our ward round checklist. So it doesn't sit in isolation. It's part of a much bigger picture for delivering care. Some of the key members of the team that have helped us get to this is we developed MDT coordinator roles. So we have a team of MDT coordinators who support us not only in the MDT, but auditing the wider clinical teams to make sure that we are actually asking the patient what's important to them. And if any of our community nurses are in the room, I apologise, but when we first introduced IPOS and outcomes, the community nursing team in particular were completing the IPOS for the patients and families. We knew that because they had to tick to say they were doing it. And we couldn't quite understand that because they were the weller patients, because those patients were at home. Because we were auditing, we were able to go back to them and we were able to actually then use a little bit of peer pressure to say, well, why are you doing this with all your patients when actually your colleague down the road is actually doing it with the patient or the patient's doing it themselves. So the MDT coordinators have been key not only to supporting MDT, but to the audit process and to training and development of new staff with OAK and IPOS. Assistant practitioners on our inpatient centre and in our day centre, we knew that our medical teams and nursing teams were already quite overloaded with paperwork, and actually to give another piece of paper for them to work through with patients and families was perhaps a little bit too much. Thinking about our workforce and our future workforce, because we know there's a national shortage of nurses, we know within medicine there are massive challenges getting medics into the profession, although the government have recently done something, well, trying to do something about that. We decided that what we had within our healthcare assistants was a really strong team who actually probably our turnover is less of, and actually why wouldn't we look to develop them? So we're actually going down the route in Sheffield and in Doncaster and Bassetlaw with our university and local college of assistant practitioner. I know some organisations will be pilot sites for associate nurse, but those assistant practitioners have led IPOS and patient outcomes on our inpatient centre and in therapies. And actually they go with no preconceived ideas about what's important to that patient, and they in a very natural way get the information from the patient. And I'm not sure we would have been as successful as we have been without them supporting us. And alongside all of this, and they're just the headlines for how we've embedded it, we've had an IPOS user group. That group's actually now folded, but in the early days we met on a weekly basis, then a fortnightly basis, so that as executives we were absolutely connected to the people within the organisation who were operationalising IPOS. So what has that all meant in terms of MDTs? Well, they're clearly no longer cathartic. They are very structured, they are very fast-paced, but actually there's absolute equity because of our complexity framework in our community team. On the referral, a patient comes into MDT, and then we determine from their outcome scores and the discussion we have and the complexity that we agree and validate in MDT when they are next going to journey into our MDT meeting. So no patient can get lost in the system, and if there's a change of phase, then the patient is brought in at an earlier point than we would have agreed previously. I hope that makes sense. Within our inpatient centre, our MDT time is now 2 hours 30 minutes. There's a consistent chair. The medics no longer lead those MDTs because they're an integral part of the MDT discussion. And I, on a personal level, would challenge anybody to chair a meeting and give valid contribution. It's now an impossible. Community is now 4 hours in total. This slide's subtly out of date. It says we discuss up to 50 patients a week. I think it's probably nearer 60 to 70 patients a week that we discuss, which is what we have to do given the volume of patients sitting within community. And in our therapies, we have a very structured MDT in line with the other 2 MDTs, so there's consistency, there's equity for all the patients in our service, and that MDT is an hour and a half. So we have now gone from 13.5 hours of MDT to 8 hours. MDT is just part of it, but actually MDT is the part of our organisation that validates our practice alongside nursing handover, consultant ward round checklists. So it's all part of a process. So I'm not going to spend long on this, but we're happy to share these with you. This is our phase of illness. It is subtly different to phase, and we have had conversations with Fliss because what was really important to us was to look at the dying phase in a little bit more detail, because we have patients that die low complexity and their families are less burdensome on the nursing and medical teams than others. We have patients who die high complexity in significant agitation and distress, and we have families who are so troubled during the dying period. And so we felt it really important to distinguish dying low complexity and dying high complexity. It works for us. It is a slight deviation to the work that Fliss and the team have done. We then looked at the IPOS tool, and in order to structure it within our MDT, we actually categorised it, colour-coded it, so that we have pain, we have shortness of breath, we have other physical that takes all those elements of IPOS into account, psychospiritual, again taking the psychological aspects and spiritual aspects of IPOS, and then family carer discharge. So it is very, very structured, and that enables us to have a very clear structure in our MDTs. The documentation we used to support MDTs, we looked at how we pulled that in from Infoflex. IT have been critical to this project and rollout, because without them this would have been very difficult to do, but it means that we have a great systematic approach to the recording of our data. So that is a nutshell what we've done. Before we go on to the next chapter, we're going to show you just a 2-minute extract from one of our MDTs. So hopefully what I've just described to you, you can realise how it works in practice.
So this is an extract from our inpatient centre MDT.
Admitted on the 25th of September, malignant neoplasm of nasal cavity, secondary malignant neoplasm of liver, lung, brain and cerebral meninges. This gentleman's got a DNA CPR status. I've got him down as unstable, almost completely bedfast, and I haven't got preferred location of death. Is that right? Okay. This gentleman last completed his IPOS on the 19th of October with the help of Zoe Reedy. He rated his overall quality of life as 3, said things had got a little better and he always got the information that he wanted. And the problems he identified over the last 3 days was his hearing has got worse. His pain severity status is 0. It's been 0 for the last 3 IPOSs. Last week we heard there were no issues or actions. Is that the same?
Yes, pain is not any pain at all.
Brilliant. Shortness of breath, I've got down this week as 3 severe, bearing in mind that since admission his last 3 IPOSs have been 1. So there's a change there.
What was the date of this IPOS?
The 19th.
So I saw him today and he said he has been a bit more out of breath just recently. So it's not quite as good as he was when I've seen him today as he was previously, especially last week. He's got a bit of a dry cough as well, which I noticed after he'd had a little sip of water. Whether the two are linked, I'm not sure, but we might.
I suppose it would just be monitoring just to check he's not bringing a chest infection.
I know,
That's
yeah.
actually
I
starting
didn't
to
hear anything
manifest
today,
itself.
but I think he's at risk.
Okay. Other physical symptoms, he's scoring 3 severe, 3 for weakness and lack of energy. When he came in he was scoring 1. The last 2 IPOSs were 2, so that's something that's deteriorating for him. He scored 3 for a dry sore mouth. Equally, previously he scored 0 and then 1 for that. Across the other domains he's scoring 2 for vomiting, and that's it. Okay, so that's just a very brief snapshot. Apologies, some of you may not have heard that very well at the back. Sam's now going to talk to you about the next chapter and how this project and rollout continues to evolve.
We can't underestimate for us how important it's been to make these outcome measures part of what we do as a team, and to help our team understand what they're there for. And so as a consultant, you get the feedback about what your patient is experiencing. As the medical director, you get the understanding of the governance arrangements and how your team is functioning and how your service is functioning. And it gives us the capacity to describe that to our to our chief executive, to our board, and hopefully in the future to our commissioners. But we kind of needed to grow this, because I think the inpatient centre was the place that we started this journey for us, and an inpatient centre is actually very safe. I mean, in hospice terms, it's a very safe place, and it was safe because we have regular contact with all the clinicians who are engaged. It's a much easier environment to introduce things and control it as we try to grow. But we realised, and there's a very fixed number of patients who are there at any one time. But what we recognised is that the areas where we needed to implement these outcome measures, which had their own challenges, were community and in our community team. And how could we manage to run an MDT like that with expanding numbers of patients, with expanding complexity, or increasing complexity? We really needed to think very hard about that. And it presented, during the period of implementation, a few challenges. And we were very fortunate to be approached by the Clark, Yorkshire and Humber at that time around a software tool called eShift, and there'll be a demonstration if you are interested during lunchtime to see how that works. But just as IPOS filled very nicely an IPOS-shaped hole in our processes, what eShift did was it allowed us to imagine how we might do things differently in community and how we might reach out, and how we might apply outcome measures and care in a way that was deliverable across the piece and with really challenges. I mean, I think for all of you who work in recruiting specialist palliative care clinicians, particularly specialist palliative care nurses in community, I mean, my experience of that is that we have quite a shallow pool of specialist nurses of which to call upon. And, I think it's very, very challenging to upskill and train nurses coming in at different levels, at more junior level, and get them to a level of experience where they can function as a band 7 out there, looking after some of the patients with most complex need. And what the tool allowed us to do was to think about how we might address that. And I'll describe it a little bit in more detail. But what was useful was thinking about partnerships, thinking about partnerships as a hospice with the NHS, thinking about academic partnerships to give rigour to what we do and to allow us to analyse what we do effectively. And that was something that really was born out of our engagement with the Palliative Care Funding Review and our fortunate engagement with Public Health England in their pilots, because I think what we recognised was actually by engaging and developing rigour, it allowed us to develop systems that worked properly and were validated. And then also it allowed us to also think about private industry and how technology might help enhance what we do. And so we developed a pilot system in collaboration with our partners. And this model basically describes what that system involves. At the heart of it, there's the patient record and patient information. And in there, essentially sit our outcome measures. Now, I think Antonia talked about outcome measures, not confusing outcome measures with your assessment tools. What the outcome measures in the process that we implemented did was it allowed us to focus down our attention on the problem areas for the patients, and then we could do a deeper dive, a more detailed assessment into those problems that the patient had, using a range of different tools to describe and communicate that information effectively. Now, what Encompass did, the Encompass project as it became known did, was then allowed us to use those outcome measures as a communication tool, a new language to help us consistently communicate within our teams and between our teams. And so what it enabled us to do was take a bedside nurse, this blob here. It enables to take the bedside nurse and basically examine the patient's experience, the concerns to them. They could then digitally enter that information into the record system. That information would automatically then be communicated up to a delegating nurse or a delegating clinician. And that senior clinician could then review the information, establish if any specific additional action needed to be taken. It allowed that peripheral bedside nurse to ask questions and inquire, and they could request assistance, or the senior clinician could offer more detailed advice if they felt that there wasn't enough information coming through. It also allowed our senior clinician to access a whole host of clinical records, and as part of the project, what we're also hoping to enable our peripheral nurse to be able to access all the clinical records that they need. So for a band 6 and a band 7 nurse, very experienced, or a community medic or a registrar out there, what they'll be able to do is go into the record, go into the x-rays, go into the blood tests. They can look at the objective information, assess the clinical history, and they can ask for support if they need it. Now, if you work in community, you'll recognise that that whole process normally would probably take about a week, if not 2, because the clinician would return to base, they would have a discussion with, if they were lucky that day, with the consultant or the clinician who was around. If not, more than likely, they would have to wait till the end of the week. Did they actually recognise how significant the patient was? Well, without outcome measures, sometimes we would ask the questions of things that we thought were important as clinicians, not necessarily get to the heart of the problems of the patient that they were experiencing. And so then that process, and then actually then to go back to the patient and implement your plan, and then assess that change, the impact of that change, could easily take 2 weeks. And what this process allowed us to do was to transform that whole feedback process, the assessment process, determining outcome measures into a matter of seconds, and really turn around the speed with which we could do that. You then implement your processes differently, you digitally capture that information, and you then analyse it in a daily board round. You return, so your team meetings become more effective. And it allows you to do daily team meetings, to analyse and manage the flow of patients, to allocate resources. And it also allows you to, at your MDT, have more complex discussions about more challenging situations. So how does it actually work in practice? Well, for us, it allowed us to take a step into the unknown, and I'm a bit of a geek, so I love the technology thing. But I suppose we need to be very aware of the challenges for engaging our staff in using this kind of technology and what they do. You need to be patient, you need to be supportive, it's step at a time. But what it's allowed us to do is to capture the information on smartphones out in the field, or we can use tablet computers or laptops to do our assessment. The way that the information also works, not to terrify any of our community nurses who are in the audience, but it also effectively allows us to automate a time in motion. We can, the software allows us to navigate people to their houses in the most efficient route, so that they're not going all around the houses, or alternative, not that our team did ever do that, but nip into Sainsbury's during the course of the day. It also allowed us to time that, and then we captured our objective measures at check-in, and all that information was constantly being fed and recorded to allow us to manage it on a clinical team level, but also on an aggregated service level. You can't see this particularly well, so my apologies for that. But essentially what we could do is we then were able to generate MDT lists. So this is just information that's just gathered in the course of an assessment. All of that information is then pulled in and aggregated into MDT lists, and it allows us to much more efficiently generate MDT work lists that we work around. For our MDT coordinators, they have really been our eyes, our hands, really to make this process work. But the work that they've done has been so massively labour intensive in terms of gathering resources and moving things around. And what we've been able to do is use this technology to make that process much, much more efficient. And it continues to be refined. But once that information is gathered, there is no additional work to do in terms of aggregation. The information then goes into the system, and it allows us to track the patient experience. I need to use that carefully, because these aren't experience measures, these are outcome measures, but it allows us to track the experience. And what we can see in the course of our MDT, there's a very visual display. This is just a very small example of pain is the red line. We can track the pain experience. Green is the breathlessness. There's a dot which represents other physical problems, and we can track the impact of the patient's symptoms on them. And we can then really discuss and analyse that situation in the MDT in real detail. We've also got the benefit of them being able to look at the information in a series of aggregated ways. Now, what I'm just going to do is just very briefly show you our transition MDT. Okay, so what you saw before was the inpatient centre MDT. This is what I'm going to show you now is a transition into a community MDT. MDT performs several functions. It performs a function of, let me just pause this a minute. MDT performs a function of really acting as the central point to communicate, share information, but also acts as a centre for education. So our team members gather around, they share with each other, they share experience. It's not cathartic, it's focused, but it allows us both to manage governance, manage clinical care, and educate our team members. Get the right video for you. Now, in this one, this is a shorter version, but the advantage of this video here, another thing that the technology has allowed us to do is to potentially carry out our MDTs remotely. Because the system is accessible from anywhere, what it means is that we can have a community nurse who's actually out in the field on the spider telephone. They can access and see all the information as it's being entered and processed live, but they don't actually have to be in the room. So it's given a new dimension to what we potentially can do, and we believe there's great potential to expand beyond that.
A 75-year-old lady, malignant neoplasm of breast, secondary malignant neoplasm of lung and chronic kidney disease stage 3. This lady's got a DNA CPR status. She's down as deteriorating. Preferred location of death, patient's own home, and AKPS of 20. Is that right?
That's correct, yeah.
This lady hasn't rated her overall quality of life. She hasn't said whether the palliative care team have made a difference, but she's identified her main concern over the last 3 days as limited mobility. Her pain severity score, Dave, when you last visited on the 22nd, she hasn't got a score. Previously, though, it was 1 mild. Have you got a score?
Yeah, it's 1.
Okay,
she just described generalised aches from being in bed the majority of the time. She's a lady with very limited lower leg strength and needs full hoisting into a chair. But since she's been home from hospital, that's actually not happening as regularly because she's actually more comfortable in bed
Okay.
on a proper mattress.
Is she on any medication?
No, she was just taking regular paracetamol and, excuse me, has Oromorph available for breakthrough pain, but I just suggested that she might benefit from a buprenorphine patch in the background just to keep her comfortable for those aches associated with being in bed, and also discuss whether she would benefit from having some home well-being or complementary therapy because she's not able to obviously come up here.
So you think that will help? For
she was quite keen.
Okay. Do you want to talk to the wellbeing team then to see then if they could do maybe a 1 or 2 interventions?
So about home well-being,
Yeah.
and I guess in particular, if it's for pain, she might benefit from Reiki.
Absolutely.
Okay. So the format and the shape is roughly the same, but what you'll notice is that our clinical notes, we haven't got tables littered with clinical records. The clinicians can access the information they need to hand very quickly and very easily. And this is the benefit of introducing kind of a technological enabler into the process of outcome measures. So these are just other opportunities that we've identified. As we said with Clarity, if the system won't crash. With Clarity, that's another module to the tool that we've started to explore, and that allows us to look at the information in terms of patient contacts, hours spent. We can look at really a whole service and how that is working using automatically anonymised data. And they've used this at commissioning level in Canada in their CCACs, which are kind of a morph of old PCTs and current CCGs, to actually live monitor and manage the commission services. For us, we see other opportunities using the software and potential benefits of Clarity to allow us to case manage our individual patients, to develop aggregated reports to allow us to demonstrate both to the NHS, to our board, to our service users what we deliver, but we also see that there's significant potential to develop research reports as well, and that's something that we hope to progress. In a nutshell, outcome measures, whether it be IPAWS or the other Oak suite of measures, really sit at the heart of Encompass. They're the kind of axis around which the whole process spins. And it's the processes that we put in around it are the things that make a difference to how we deliver the service. So it is not good enough, in my perspective, and our perspective, I would say, to just develop outcome measures which are designed just to give to the patient and then on their own, be used to present aggregated data. The aggregation of the data is critical, and we're really delighted Heather's going to tell us about that. But what we really need to do, for us as well as that, is make it meaningful to our clinicians. If you want to be successful in making this work and getting your teams to engage, they need to see the benefits of what the systems deliver. And from the perspective of our teams, they see that in our MDT meetings, they see it, they feel it, they hear it. What's delightful for us is, in being part of those meetings, and what you may have noticed is that Judith actually chairs our meetings. What the difference, I guess, is me not as a consultant chairing those meetings. What it's allowed me to do is it's allowed me to contribute in a way where trying to manage the timings of the meetings, manage discussions and from everyone, it doesn't become an issue. And if you ever come and visit our MDTs, you'll see that very quickly that even when I step out of line, that's brought very much into sharp focus. It focuses our mind and it makes sure that we're progressing appropriately and efficiently through the meeting. It also means that the meetings are truly multidisciplinary, and what you'll see if you want, I think we've got the capacity to show the videos, fuller videos later on, is it means that the other team members contribute. Your AHPs recognise the place where they have a contribution to make, whether it be about mobility or whether it be about pain or whether it be about breathlessness. The nurses recognise where they need to contribute. It doesn't become a purely prescribing-based model. It becomes a holistic model where everyone has a contribution to make. And by putting outcome measures, and in particular for us, IPAWS and the associated Oak measures at the centre of that, that's made a massive difference. If you want to do this effectively, from our perspective, and I suppose I need to be careful. Again, we're not saying that this is how you ought to do it. I think what we've learned is that this journey has required us to be individual, to reflect on the measures, on that beautiful, if I think back to Antonia's picture with all the horticulture and that well-cultivated garden. You know, what we want to do is we want to know exactly where we want to put those flower pots and flower baskets. We want it still to be ordered. We don't want a wildflower meadow. What we want is a process where we know and can appreciate the fruits of our labours. And so we have found that what we really needed to do was to think very carefully about when those measures are taken, who takes them, where the feedback comes in, how it influences our practice. In order to do that, it requires significant service development, service change. And that is for teams that historically are quite fixed, and I'll potentially be a little bit controversial here. In palliative care, we can get very, very fixed into a way of doing things. And, you know, almost palliative care, I think, in the discussions that I've had and that we've had, really started as a disruptive technology. It was saying things aren't right, we're going to do something different, we'll generate a disruptive technology that will make things better. And that's exactly what happened. That's what Cicely Saunders did, that's what Eric Wilkes did. They created this disruptive technology that made a difference. But then what's happened latterly is that those technologies have become fixed and we've become less able to be flexible. But in order to be flexible and to create uncertainty within your team, you need to have kind of real leadership, executive ownership of this. And so, as Antonia said, as we've experienced, really the leaders within your organisation need to understand what these measures are, what they're for, how they can be used. But also your clinical teams need to own them. They need to belong to them and they need to understand how that can influence care. Clinical IT support is really essential. You know, that to do all of this by hand, in our experience, is going to be very, very difficult. We're really fortunate that we've had our clinical IT team, our MDT coordinator, our IT manager, really at the heart of these processes. And I think if you're going to do it, I would certainly suggest to you that that's a really critical step. As we've already described, we need to have a tangible impact of outcome measures. So feed them into your MDT, feed them into your handover, feed them into your ward round. That's what worked for us. We need to know that these measures empower patients, and our staff are all about our patients, and when they see that they empower patients, when you describe that, it can make a massive difference. And then we need clear and regular communication, and for us that was through the our IPOS user group during implementation, you know, weekly meetings to talk about what the problems are, where the wrinkles are, having updated work lists, having problem lists where frequently answered questions can come up and they can be addressed. The team need to see that you're hearing the challenges that they're having and that you're responding appropriately. And that's what the user group was for. It was listening to our teams, modifying our approach, being flexible, service improvement, really as we know it. And it's allowed us to think laterally.
I'm Dida Cornish, a consultant at St Peter's Hospice in Bristol. I was just wondering how often you do the full IPOS on your inpatient unit, whether it's just a change of phase or it sounds as if possibly you're doing it more often, and how burdensome or not the patients find that?
Okay, on our inpatient centre we do IPOS on day of admission and then every third day unless there's a change of phase. If there's a change of phase, that immediately instigates a new IPOS. And when we were talking about embedding it into practice, I probably didn't touch enough on the nursing handover because IPOS and outcomes are fundamental to that. So at 7 o'clock in the morning when the nurses have their handover, that's where they will identify first thing if there's a change of phase. If there has been, a new IPOS will be instigated. We also do it on day of discharge, even if the IPOS was only done the previous day, just to make sure that on day of discharge nothing's changed for that patient. Is it burdensome for our patients? We actually, and Claire's here today, our service user coordinator, and we do IPOS. We actually ask our patients a huge amount nowadays. 5 years ago, we didn't burden them with any questionnaires. We do a lot of service user feedback, but the feedback we've had to date, and Claire can correct me if I'm wrong, is no, patients aren't overburdened. And actually, our assistant practitioners are very creative in the way that they work IPOS with the patient. So for the patient who is tired, is fatigued, they won't just give them the document and say, fill this in the next 5 minutes. They may be bathing the patient, they'll have the conversations, and that patient actually tells them their IPOS scores without even knowing it. Other patients absolutely love it. And, you know, we had a letter from a lady whose husband died on our inpatient centre, and she actually said, would you please send me the form that I completed with my husband every day, because it was so important to us that you really cared about us, and I want to show my family and friends. And there are patients who don't want to complete it, and if they don't, we tick that part of the box and then the staff complete it for them.
I think there is the other issue about we try to be consistent and objective, but we're not slaves to the process. Underpinning this process are people, human beings who need to be supported. And it's that we try to ensure that we're consistent, but actually if a patient really doesn't want to fill in the questionnaire, that's all right. They don't have to. A staff member can complete the portions of the questionnaire that are relevant and are important, and that information will go into the system. You know, so, and because it becomes part and parcel of what we do, in a sense, people don't really know what they don't know. So when they arrive and that's normal, it becomes normal, and people are actually surprisingly engaged and supportive if they think it's going to help them.
And just in case anybody's wondering, in community, IPOSs are completed on first contact with the clinician and then every visit, and a new one's done if there's a change of phase. In our day centre, we do it on first contact in the centre, then every third visit, unless there's a change of phase. And MDT is the organ that actually ensures that that's happening.
Thank you very much for your time.